On behalf of the PREDICT network of emergency departments across Australia and New Zealand, I present the cost-effectiveness of patient observation on cranial CT rates in children with minor head trauma, the Australasian Pediatric Head Injury Rule Study. The APHIRST study was funded by multiple foundations and agencies in Australia and New Zealand. I have no financial relationships to disclose or conflicts of interest to resolve. The management of children with minor blunt head trauma often includes a period of observation to determine the need for cranial CTs. Prior research has shown that observation of children with mild blunt head trauma in the emergency department is associated with lower CT rates across all pecan TBI risk groups and progressively decreases with each hour of observation, with no impact on missed clinically important TBI, which is defined as intubation for more than 24 hours, a positive in association with a positive CT scan, hospitalization for 2 or more nights, neurosurgical intervention, or death following head trauma. The 3 pecan TBI risk groups predict the risk for CI-TBI. The high risk group predicting a 4.3% risk for CI-TBI. The intermediate risk group predicting a 0.9% risk for CI-TBI. And the very low risk group predicting a less than 0.02% risk of CI-TBI in those less than 2 years of age, and less than 0.05% risk of CI-TBI in those 2 years of age and over. Using these definitions, we explored the relationship between planned observation and CT use in Australia and New Zealand. This was a planned sub-analysis of a prospective observational study at 10 pediatric emergency departments. Children less than 18 years of age with GCS scores of 14 or 15 presenting within 24 hours of blunt head trauma were enrolled between 2011 and 2014. After the initial assessment, clinicians documented responses to 2 questions: if they plan to observe and if they plan to obtain immediate neuroimaging. The planned observation cohort included patients with a plan of observation and no plan for immediate CT. The no planned observation cohort included those with a planned immediate CT or no planned observation. The CT rate in the total cohort was 8.6% with a CI-TBI rate of 0.8%. Patients in the planned observation cohort had a significantly lower CT rate of 4.3% and a 0.4% CI-TBI rate as compared to those with no planned observation. Multivariate logistic regression using generalized linear models with mixed effects, adjusting for time from injury, patient characteristics, history of seizure, pecan TBI risk groups, and hospital cluster effects determined that patients in the planned observation cohort had an 80% lower adjusted odds of cranial CT use when compared those with no planned observation. Further, planned observation in those at high risk for CI-TBI was associated with an adjusted odds ratio of 0.1, and planned observation in the intermediate risk group was associated with an adjusted odds ratio of 0.21 when compared to no planned observation. However, there was no difference in the adjusted odds of cranial CT use for the very low risk group with planned observation. And these results have been published. The objective of our study was to estimate the cost effectiveness of planned observation on CT use among children with minor head trauma. Taking an Australian healthcare perspective with an acute care time horizon, we applied direct and indirect hospital costs from a single-center tertiary academic children's hospital. Children with head injuries were identified using ICD-10 codes between 2011 and 2014. The costs in Australian dollars were inflated to 2018 and applied to patient-level data of the APHIRST cohort. We used the upper and lower confidence interval values in our sensitivity analysis. We estimated the cost-effectiveness of planned ED observation on reducing CT use by net benefit regression using ordinary least squares with robust estimations and bootstrapping, adjusting for patient characteristics and risk for CI-TBI for the total cohort and each PCON TBI risk group. Planned ED observation was cost saving of $135 and associated with a 10.4% lower cranial CTUs when compared with no planned observation. Further, planned observation in the PCON high-risk group was cost saving of $1,160 and associated with a 43% lower CTUs when compared with no planned observation in the PCON high-risk group. Similarly, planned observation in the PCON intermediate risk group patients was cost saving of $86 and associated with 11% lower CTUs as compared to no planned observation in the PCON intermediate risk group. Finally, planned observation of patients in the very low risk group was more costly and minimally effective in reducing CTUs when compared to no planned observation in the PCON very low risk group. The cost effectiveness plane depicts the incremental cost on y-axis and incremental reduction in CTUs on the x-axis. The right lower quadrant in the cost effectiveness plane depicts the strategies that are cost saving and effective in reducing CTUs. The total cohort in black, the PCON high risk group in blue, the intermediate risk group in red, and the very low risk group in green. Planned observation was cost saving and reduced cranial CTUs by 10% in the total cohort as depicted in black. Specifically, for the groups at high risk and intermediate risk for CI-TBI in blue and red, planned observation was cost saving and effective in reducing CTUs. However, in the very low risk group depicted in green, planned observation was more costly and minimally effective in reducing CTUs. The cost-effectiveness acceptability curve shows the uncertainty of the results across different willingness to pay thresholds. The willingness to pay reflects the amount society is willing to pay for 1% reduction in CTUs. Since this value is unknown, we calculated the probability of achieving cost effectiveness across numerous willingness to pay threshold values from 0 to 300,000 Australian dollars. The total cohort depicted in black, the PCON high risk group in blue, the intermediate risk group in red, were cost effective across all willingness to pay thresholds at close to 100% probability of being cost effective. However, the very low risk group, depicted in green, achieved at best a 50% probability of being cost-effective at a threshold level of $300,000. The sensitivity analysis report that the results were consistent across the 95% confidence interval values of the cost inputs, with the lower cost on the left and the higher cost on the right. There was no difference in the results for the total cohort and all three pecan TBI risk groups with planned observation, and the very low risk group achieving at best 50% cost effectiveness at the $300,000 threshold with planned observation. There are several limitations with our study. First, our research takes an Australian public healthcare perspective and has limited generalizability. Second, with an acute care time horizon, we do not consider the long-term costs of TBI and radiation. Third, the intention to observe before deciding to obtain a CT was not clarified. And finally, the two groups were not similar. Although we used multivariable logistic regression to adjust for the impact of these factors on CT use, there could be some unaccounted residual confounding bias. To conclude, even in the setting of low overall CT rates for minor blunt head trauma in children, planned observation in the emergency department is associated with lower CT use and is cost-saving. This strategy is particularly cost-effective for those at intermediate or high risk for CITBI. However, children at very low risk for CITBI do not need CT scans, and planned observation is neither effective nor cost-effective in reducing CT use. I would like to acknowledge my colleagues and supervisors on this bicontinent collaboration, specifically Professor Hodge for guidance with the economic analysis, Dr. Holmes and Dr. Kuppermann at UC Davis, and Dr. Franz Babl at the University of Melbourne. Thank you.